Hello all, I'm here to present a seminar about head and neck space infections. This is Dr. Arun Krishnan from Department of OMFS from Sri Balaji Dental College and Hospital. Moving on into the space infection, you have to know about what is fascia. Fascia is defined as a layer of fibrous connective tissue underlying the skin and surrounding muscles, bones, vessels, nerves, the organs. So in this picture we can see about the layer of the muscle fibers and the layers of fascia. Fascia is nothing but a layer of fibrous connective tissue which is present underlying the skin and the surrounding muscles, bones, vessels, nerves, the organs. So the fascia of the head and neck is divided into two layers, superficial fascia and deep fascia. This is the deep investing fascia in which the intermembranous layer of superficial fascia, fatty layer of superficial fascia can be appreciated in this picture. The location of the fascia, the deep fascia is found between the adjacent muscles, while the superficial fascia is also known as hypodermis is found between the skin and the muscles and also contains adipose tissue. Further, the deep cervical fascia is divided into further two more layers which will be discussed in the later slides. Superficial fascia, the two layers known as campos, superficial fatty layers, the scarpas, the deep membranous layer. The contents of the superficial layers it contains the cutaneous nerves, arteries, veins, and the lymphatics. Superficial fascia, as we discussed before, it is attached intimately deep to the skin. It's most elastic, and the function of the superficial fascia is separation of the skin from the deeper tissue, making the skin, as we said, it's more elastic, more independent. Contents fat, cutaneous vessels, cutaneous nerves, lymph nodes. This is the platysma muscle. It's covering the anterior triangle covered by the superficial cervical fascia, the muscles of the facial expressions. The deep fascia is divided into two. The deep fascia, the face and jaws, the deep cervical fascia. We will not be going deep about the deep fascia and the superficial fascia alone. Not to know about the anatomy of the head and neck spaces, we'll be having a brief discussion about the fascia, and we'll be moving on to the various spaces and the space infection of the head and neck. So in order to summarize, the layers of the fascia of the head and neck is divided into superficial fascia and deep cervical fascia. The deep cervical fascia, superficial fascia, as we explained about the contents and we saw about what and all are present and what is the function of superficial fascia. The deep cervical fascia is divided into three layers like anterior, middle, and the posterior layer. The outermost layer is superficial, while present beneath the muscles in the deep cervical. Anterior layer is investing layer, paratidomacetic, the temporal, while the middle layer is sternohyoid omohyoid division, sternothyroid thyrohyoid division, visceral division. Under the visceral is buccopharyngeal, pretracheal, retropharyngeal. Posterior layer, LR division and prevertebral division. So as we saw in the previous slides, the deep fascia, anterior layer, these will be present. Superficial layer of deep cervical fascia or the temporis muscle, superficial layer of deep cervical fascia attached to the lateral orbital wall, TMJ, superficial layer of deep cervical fascia of the parotid gland, over the masseter muscle, over the buccinatum muscle, over the trapezius, investing the sternomastoid muscle. Middle layer, sternothyroid omohyoid layer, sternothyroid thyroid, pretracheal layer, prevertebral buccopharyngeal fascia. The same picture was explained in a different slide. This picture we can see about the carotid sheet, sternohyoid, visceral portion of the pretracheal layer, prevertebral layer, in relation to the parotid gland is superficial, the anterior layer. Deep fascia, posterior layer. The posterior layer, so discuss about the carotid sheet, prevertebral, alar fascia, carotid sheet, infrahead fascia can be seen. The deep fascia, the face and jaws are divided into temporal fascia, covering the temporalis muscle and structure superior to the zygomatic arch, mesenteric parotid covering the masseter and structures inferior to the zygomatic arch surrounding the parotid gland, pterygoid fascia covering the medial surface of the medial pterygoid muscle. These three layers are continuous with each other, forms the investing layer of the deep cervical fascia. So the layers of the deep cervical fascia of the neck are divided into investing fascia, pretracheal, prevertebral, carotid, and buccopharyngeal. These are things in order to summarize. The investing layers of the deep cervical fascia surrounds the neck like a collar, as we can see in this picture. It splits around the two muscles, namely the sternocleidomastoid, SCM, and the trapezius muscle. Anteriorly, now the borders, anteriorly it's attached anterior to the inferior hyoid bone, superiorly attached to the lower border of the mandible, laterally to the mastoid process, posterior to the superior nuclear line and the external occipital protuberance, the backside. Investing layer splits to enclose the parotid gland. Superficial layer forms a parotid fascia, gets attached to the zygomatic arch. So the investing layer superiorly attached to the occipital bone, protuberance. Spinous process of the cervical vertebra, mastoid process of the temporal bone, zygomatic arches, inferior border of the mandible, hyoid. Inferiorly attached to the mandibular sterni, clavicles, acromion, stylomastoid process, and suprastern. Prevertebral fascia is firm and tough membrane that covers the prevertebral muscles, extending from the base of the skull until it reaches T4 vertebra. Prevertebral layer. This is the prevertebral layer of the deep cervical fascia. The prevertebral layer of the deep cervical fascia, it covers the muscles that forms the floor of the posterior triangle of the neck and all the cervical nerve roots. In front of this fascia, it is the present is the retropharyngeal space. So these are the areas, spaces are the areas where the infections will get occur. So we saw about the prevertebral fascia, it's pretracheal fascia, thin fascia lying deep to the infrahyoid strap of the muscles like sternohyoid, sternothyroid, normohyoid. Support attachment is at the body of the hyoid bone and the oblique line of the thyroid cartilage. The pretracheal layer splits to enclose the thyroid cartilage and adheres to it at the back of the isthmus in second, third, and fourth ring of the trachea. Laterally, it fuses with the front of the carotid sheath and the deep surface of the sternocleidomastoid muscle. It also surrounds the pharynx, esophagus, larynx, and trachea. Behind prevertebral fascia is the prevertebral space. So, carotid sheath distributed deep to the investing fascia, as we saw in the first slides, in the sternocleidomastoid muscle on the base of the neck, thorax. The contents, it consists of the ICA, CCA, internal jugular vein, and the vagus nerve, nerve. So we saw about the anatomy of both the facial spaces present in the head and neck, fascia. Now we are moving on to the facial spaces and the infection occurring from the facial spaces. So the facial spaces are nothing but the potential spaces found between the layers of the fascia. It contains loose areolar connective tissue, making them potential spaces are not actual spaces unless infection of those spaces occur, leading to the displacement of the loose connective tissues. And also during surgery, these spaces are opened up. So classification is divided according to the position. Space of the jaws, face, second class 2 is about the face of the space of the neck. In the space of the face and jaws, vestibular spaces, canine spaces, buccal space, parotid space, masticator space, submandibular, sublingual, submental, and palatal spaces. Space of the neck, parapharyngeal, this lateral pharyngeal space, and retropharyngeal space. So the classification according to the first we discussed about the based on the mode of based on the position. Now according to the mode of involvement. First primary maxillary spaces, primary mandibular space, secondary facial spaces. The same classification is discussed about the maxillary and the maxillary canine buccal infratemporal and mandibular, submental, submandibular, sublingual buccal and a secondary mesenteric, pterygomandibular, superficial and deep temporal, lateral retropharyngeal and all the others discussed about parotid spaces. Another classification according to direct spread of infection, primary spaces are those that are the spaces that directly adjacent to the origin of odontogenic infections. Secondary spaces becomes involved following the spread of infection to the primary spaces. So they occur from primary to secondary. This masticated tissue spaces, parapharyngeal and prevertebral spaces. So the classification, the other classification is Holland's head classification 958, infrahyoid spaces, visceral component, visceral space in the other spaces. Under the infrahyoid spaces, the visceral component, it contains pretracheal, previsceral, and retrovisceral, and the visceral space, other spaces, cavity within the carotid sheath, spaces between the two layers of prevertebral fascia. Anatomic spaces of clinical significance, Goroditsky and Holyoake classification. Space 1, platysma and investing fascia. Space 2, investing and infrahyoid fascia. Space 2A, it's nothing but the infrahyoid among the infrahyoid muscles. Space 3, pretracheal and retrovisceral. Space 4 is known as danger space. Space 4A, prevertebral and investing fascia. Space 5, within the prevertebral fascia. So this is the numbered spaces of the Grodinski and Holyoke deep space of next 1938, space 1, 2, 3, 3A, 4 is not space. Space 4 is known as danger space, lies between the alar and prevertebral division of the posterior layer of deep cervical fascia. Space 4A lies in the posterior triangle of the neck, posterior to the carotid sheath. Anterior border is alar layer of deep cervical fascia. Posterior border is prevertebral layer. It extends from the skull base to the diaphragm. Why it is known as danger space? It is known as danger at the inferior border. It is continuous with the posterior mediastinum containing vena cava, arch of aorta, thoracic duct, trachea, and esophagus. Erosion of any major blood vessels, lower airway, and upper digestive tract causes death of the patient. So hence it is known as the danger space. The danger space is immediately posterior to the retropharyngeal space and immediately anterior to the prevertebral face. Spread within the danger space leads to occur rapidly because of the loose areolar tissue that occupies this region. And this spread can lead to the mediastinitis, empyema, and sepsis. So this is about the source of the spread of infection from the periodontal space, parapharyngeal, retropharyngeal spaces. It occurs in danger space. So moving on to the different spaces, starting with the vestibular space. The name itself indicates the vestibular space of the maxilla, the space of the upper jaw, found medial to the buccinatum muscle, below the muscle attachment, along the alveolar process of the maxilla. Its lateral wall is the oral mucosa, communication with the maxillary teeth and the periodontium of the maxillary teeth. The vestibular space of the mandible between the buccinatum muscle and the oral mucosa, above the attachment of buccinatum muscle to the mandible. Communication, as you can see in this picture, the mandibular teeth and the periodontium. Canine space. The canine space is also known as infraorbital space. It's located superior to the upper lip and lateral to the apex of the maxillary canine. It's present between the skins and the muscles of the facial expression. So any infection in the canine space leads to the difficulty in the to lack of the facial expressions, and eye movements will get hindered. Between the skin and the muscles of the facial expression, levator labii superioris and zygomaticus major in the canine fossa. This picture indicates about the spread of the infection from the canine fossa to the following mesenteric spaces and the lead to mesenteric space infection. The canine space of the infraorbital space boundaries: anteriorly orbicularis oris, posteriorly buccal space, superficially quadratus labii superioris muscle, deep levator anguli oris, anterior surface of the maxilla, medially levator labii superioris elecunacea, laterally zygomaticus major, superiorly quadratus labii superioris, inferiorly caninus muscle, which communicates, as I said in the first picture, it communicates with the buccal space and cavernous sinus via the venous communication. Contents: the canine space consists of the infraorbital nerve, angular artery, and vein. So the canine space clinical evaluation: patient exhibits swelling, obliteration of the nasolabial fold, swelling of the upper lip, edema occurs in the upper and lower eyelid. Source of infection is the maxillary canine tooth. Clinical features: loss of nasolabial fold, edema of the lower eyelid, swelling of the cheek, upper lip, drooping of the corner of the mouth, sometimes spontaneous discharge from the medial canthus of the eye. Surgical management: incise high in the maxillary labial vestibule, hemostat advanced to the levator anguli muscle and place a rubber drain and suture into the lower margin of the vestibular. Second, a hemostat is then inserted, which is placed at the depth of the accumulation of the purulent accumulation until it comes into contact with the bone, while the index finger of the non-dominant hand palpates the infraorbital margin. Finally, a rubber drain is placed to stabilize the suture and the mucosa, as you see in the picture. Buccal space. The buccal space lies between the buccinatum muscle and overlying skin and the superficial fascia. The potential space may become involved via the upper jaw and lower molar, arch molars. Boundaries: anteriorly zygomaticus major above and depressor anguli oris below. Posteriorly anterior border of the masseter. Superiorly zygomatic arch. Inferiorly inferior border of the mandible. Medially buccinator. Laterally the skin and the subcutaneous tissue. Moving on to the contents, it consists of the fat pad, parotid duct, anterior facial artery and vein, the transverse facial artery and vein, as you can see in the picture. The communication: submesenteric space communicates with the pterygomandibular space, superficial temporal, infratemporal, lateral pharyngeal, and the carotid sinus. The source of the infection are the maxillary and mandibular premolars and molars. The clinical features, the main is the dumbbell shaped swelling will be. Moving on to the buccal space. So this is pictures the examination of the patient. Buccal space demonstrates swelling, which is confined to the cheek, the abscess from the buccal mucosa and bulging into the mouth. Surgical management. Intraoral incision, horizontal incision above the depth of the vestibule. The most prominent bulge of the buccal mucosa, avoiding injury to the parotid duct. Intraoral, extraorally, cutaneous drainage inferior to the point of fluctuation for the dependent drainage. Moving on to the parotid space, so you can see in this picture, the parotid space is evident. Boundaries, medially, laterally, and anteriorly. Anteriorly, posterior border of the ramus. Medially, investing layer of the deep cervical fascia. Posteriorly, the sternocleidomastoid muscle. So we discussed in the first few slides about the superficial and deep cervical fascia and the layers and the borders attached to it. So we discussed about the parotid layer, the superficial fascia over the parotid gland. Laterally, skin, superficial fascia, mesenteric and parotid fascia. Parotid space communication. The parotid space communicates mostly with the lateral pharyngeal, submesenteric, and pterygomandibular spaces. The contents of the parotid space are glandular tissue, parotid ducts, facial nerve, external carotid artery, retromandibular vein. Lymph nodes are the primary nodal lymph nodes of the ears and face and scalp. Clinical features. The most for all clinical features for all space infection are the firm swelling. In this parotid space infection, firm swelling is seen because the pus is enclosed within this thick layer of the deep cervical fascia. Eversion of the ear lobule, oozing of the pus from the duct, no trismus, extension of the urinogenic infection to the space is difficult since the facial covering is firmly attached to the gland. The surgical management, intraoral, through the buccinator muscle and advancing of the hemostat superiorly, intraorally. Extraorally, inverted L incision, 1 to 2 centimeter, made at the hairline and the retromandibular area, as you can see in this picture. From the lower aspect of the ear lobule to the angle of the mandible, blunt dissection of the hemostat, cautiously to avoid facial nerve injury by dissection parallel to the facial nerve. Retrotonsillar space. The borders are medially capsule of the palatine tonsil, lateral superior pharyngeal constrictor, superiorly anterior tonsillar pillar, inferiorly posterior tonsillar pillar. It contains the loose areolar tissue adjacent to the soft palate. The direction of spread, tonsillitis, peritonsillar abscess, spread to the lateral pharyngeal space, to the posterior pharyngeal and prevertebral spaces, and chest, mediastinum, and empyema. So this is a small picture to indicate about the spread and where and all it gets involved. The next is the masticator space. See, as masticator, as the name itself indicates, it explains about the branches of mastication. So the masticator tissue space enclosed with the deep fascia, the face covering muscles of mastication, the ramus of the mandible, mesenteric, submesenteric spaces, pterygomandibular space, infratemporal space, and the temporal space. The four spaces of the masticator spaces communicate with each other and with submandibular and parapharyngeal spaces. The trismus is a common clinical feature found in the four spaces of the masticator space infection. Also, pain and swollen tonsillar pillars are also evident. So, from the urinogenic infection, it involves the masseter. From there, it involves the thyroid muscle. Masticator space gets involved. From the masticator space, it involves the parapharyngeal space. And from there, it involves the parotid space, or it's vice versa. It's a circle of things. Even from any one of the space infection, the other communications will occur. Submesenteric space, as you can see, the boundaries. So, discussed previously, incision of the deep muscle. The submesenteric space between the ramus and the mandible and masseter muscle. Boundaries anteriorly, the buccal space, parotid mesenteric fascia, posteriorly parotid gland and the investing layer of deep cervical fascia, superiorly zygomatic arch, inferiorly inferior border of the mandible, medially ramus of the mandible, laterally the masseter muscle. Contents: mesenteric nerve, superficial temporal artery, transverse facial artery. The source of the infection are the mandibular third molar. Clinical features: swelling of the angle of the mandible, obliteration of the mandibular sulcus posteriorly, trismus and throbbing pain, osteomyelitis due to the relation of the masseter muscle, which is responsible for blood supply to the ramus and the mandible, supplied by the mandibular artery, leading to the occurrence of the ischemia in the bone, denuded by the periosteum, with abscess leading to osteomyelitis and sequestration formations. More important, a common clue for the diagnosis is submesenteric space infection is the subperiosteal new bone deposition. That is the most important clinical features. Pterygomandibular space, Pterygomandibular space, the boundaries, laterally medial surface of the ramus and the mandible, medially lateral surface of the medial pterygoid plate, posteriorly deeper portion of the parotid gland, anteriorly pterygomandibular raphe, superiorly lateral pterygoid muscle. The contents, it consists of the lingual nerve, mandibular nerve, inferior alveolar artery, and myloid nerve. The source of the infection of the mandibular third molar, especially with the mesioangular the horizontal impaction, fracture in the angle of the mandible. Swelling is not obvious extraorally. Intraorally, swelling will be seen on the same side of the soft palate, tonsillar pilus, and deviation of the uvula to the other side. Dysphagia, difficulty in swallowing, fever, and lymphadenitis. Surgical management, intraoral incision, vertical incision along the external oblique line of the mandible, blunt dissection and opening of the hemostat when it reaches the lateral aspect of the ramus beneath the masseter muscle. Extraoral approach, a small incision should be put beneath the angle of the mandible and the medial aspect of the ramus and pterygomandibular raphe. Treatment, IND, intraorally only pterygomandibular space along the mesial temporal crest, extraoral multiple spaces, rubber drain insertion, rehydration, antibiotic administration, bed rest. The next is about the infratemporal space. Boundaries, superiorly it attaches to the inferior surface of the greater sphenoid. Inferiorly, where the medial pterygoid muscle attaches to the mandible near its angle. Laterally, ramus of the mandible. Medially, lateral pterygoid plate. Anteriorly, posterior aspect of the maxilla. Posteriorly, tympanic plate, mastoid, styloid process of the temporal bone. Anterior aspect of the parotid gland. Contents, internal maxillary artery, pterygoid plexus, and the mandibular nerve. Source of infection, maxillary molar, local infiltration of the maxillary nerve, mandibular nerve and its branches, pterygoid plexus, which causes the cavernous sinus infection because the cavernous sinus emissary vein are in contact with the pterygoid plexus. Cavernous sinus infection, clinical features, headache, photophobia, irritability, vomiting, and drowsiness. Infratemporal spaces. Temporal space, boundaries, fascia, zygomatic arch, deep temporal, superficial and deep. It's divided into two superficial temporal spaces and deep temporal spaces, infratemporal space. So the temporal space is secondary to the initial involvement of the pterygopalatine and infratemporal space. The temporal pouch or the facial spaces in relation to the temporalis muscle. There are two superficial and deep temporal spaces. Boundaries, superficial temporal space between the temporal fascia and the temporalis muscle. Deep temporal space between the temporalis muscle and the skull. Contents. So it consists of the temporal fat pad, temporal branch of the facial nerve. The clinical features of the temporal space infection are trismus, dumbbell-shaped swelling is most constant due to the inferior boundary of the zygomatic arch, can be seen in the other space infection also. Dysphagia, dyspnea, airway compromise in the airway, severe pain. Swelling is more obvious in the superficial temporal space infection because it is only restrained by the fascia. So this, as you can see in this picture, clinical picture. Moving on to the palatal spaces. The palatal space infection to the space usually originates in the maxillary teeth, whereas the roots lies close to it. The maxillary lateral insert causing anterior palatal abscess and the posterior palatal abscess, palatal roots of the molars. This infection perforates the palatal alveolar bone and pus accumulates beneath the palatal mucoperiosteum. Usually, localization of the infection and fluctuation is hard to achieve due to the thick palatal mucoperiosteum attached to the underlying bone. Surgical management, intraoral incision done along the palatal mucoperiosteum down to the bone. The incision is made at right angle to the long axis of the teeth, carried out anterior posterior carefully to avoid injury to the palatal arteries. That's why incision is done on the alveolar mucosa rather than the palatal mucosa, not to avoid injury to the palatal arteries. Submandibular space found between the anterior and posterior belly of digastric is located lateral and posterior to the submental space on each side of the jaw. The cross section is triangular with the myloid muscle superior and medially. Boundaries, superiorly myloid muscle, inferior border of the mandible, inferior, anterior and posterior belly of the digastric, laterally deep cervical fascia, platysma, superficial skin and fascia and skin, medially hyoglossus, thyroglossus and mylohyoid muscle, posteriorly to the hyoid bone, anteriorly submental space. The contents, submandibular salivary gland, proximal portion of the Barton's duct, lingual and hypoglossal nerve, branch of the facial artery, palatine, tonsillar, glandular and submental. Communications, It communicates with the submental spaces, sublingual and lateral pharyngeal spaces. As you can see in this, the source of the infection are the mandibular molars. The clinical features. Uh, Clinical features: the firm swelling is present of the inferior border of the mandible at the point where the facial artery crosses. Obliteration of the angle of the mandible, dysphagia due to the restricted mouth opening, extension of the swelling starts from the lower border of the mandible down to the level of the hyoid bone in the shape of the inverted cone. Systemic signs of sepsis may be found. The clinical infection mostly arises from the second and third molar. Induration is erythema or seed. Trismus. Surgical management, extravascular. You can see this is extravascular incision, 2 cm below and parallel to the lower border of the mandible through the skin. Superficial fascia, platysma, and the investing layer of deep cervical fascia. 2 cm is left below the inferior border of the mandible to avoid injury to the marginal mandibular branch of the facial nerve. Blunt dissection is done cautiously to avoid injury to the facial artery anterior to the facial nerve and vein. So this picture indicates about the incision and what and all the present relation to it. Sublingual space, the boundaries inferiorly to the myelite muscle, laterally medial side of the mandible, medially hyoglossus, genioglossus and geniohyoid muscle, posteriorly hyoid bone. Sublingual space extend above the myelite muscle, contents sublingual gland, duct, lingual nerves, hypoglossal muscle, lingual artery and vein, hypoglossal nerve, deeper portion of submandibular gland. Communication, submandibular space, source of the infection, the mandibular premolars and molars, sublingual space and infection, clinical pictures, raised tongue, sublingual swelling, dysphagia, enlarged painful submental and submandibular glands, lymph nodes. Sublingual spaces, the sublingual space, the clinical evolution, edema and induration present on the floor of the mouth on the affected side, displacing tongue medially and superiorly, hot potato voice, elevation of the tongue to palate, causing airway compromise, prevents tongue patients from extending the tongue beyond the mammalian border. Surgical management, intraoral incision at the base of the alveolar process of the lingual sulcus or 1.5 cm away from the lingual cortical plate, taking care not to injure the sublingual gland or the lingual nerve. Hemostat is inserted in an anterior posterior direction beneath the sublingual gland. Submental spaces, borders, laterally anterior belly of the right and left digastric muscles, anteriorly inferior border of the corpus of the mandible, posterior hyoid bone, roof myloid muscle, lower margin, skin and the platysma muscle. Contents, the submental lymph nodes and the anterior jugular vein. Communications with this are submandibular space, sublingual space, the source of infection is the mandibular anterior teeth. Clinical features, hard midline swelling is present on the chin, dysphagia, signs of sepsis is found. Surgical management, extravascular incision to the skin, superficial cervical fascia, platysma, investing layer of the deep cervical fascia, at the most inferior aspect of swelling for a more dependent drainage. Submental space treatment, drainage is achieved by a percutaneous approach, horizontal incision in the most inferior portion of the chin, use naturals to increase cosmetically acceptable scar, intraoral drainage to the mentalis muscle to the labial vestibule. Pharyngeal spaces is divided into peripharyngeal space and intrapharyngeal space. Peripharyngeal, known as around the pharynx, parapharyngeal, retropharyngeal, both spaces are considered as the danger spaces. Intrapharyngeal space within the pharynx. So the pharyngeal space is most divided into peripharyngeal and intrapharyngeal. Peri, its name indicates it's around the pharynx, intra within the pharynx. So lateral pharyngeal space etiology, mandibular third molar area, sublingual, submandibular and pterygomandibular space infection. Boundaries, inferiorly hyoid bone, anteriorly pterygomandibular raphe, laterally ascending in of the mandible, medially pharyngeal wall. Lateral pharyngeal space or the parapharyngeal space contains carotid artery, internal jugular vein, vagus nerve, cervical sympathetic chain. A cone-shaped space with its base at the base of the skull superiorly and its apex at the greater horn of the hyoid bone. Source of infection, mandibular third molar, tonsillar infection, pharyngitis and parotitis. Clinical features, severe pain on the affected side of the throat, displacement of the tonsil, tonsillar pilus and uvula to the medial side. And the cardinal signs of the abscess, pharyngeal abscess are trismus, induration, fever, pharyngeal bulging, dysphagia, inability to palpate the angle of the mandible, tension of the sternocleidomastoid muscle due to the rotation of the neck away from the side of the swelling. The specific clinical features are anterior compartment, pain, dysphagia, trismus, fever and chills, swelling at the angle of the mandible, and the medial bulging of the pharyngeal walls and signs of systemic toxicity. In this pictures we can see. Complication, septic jugular vein thrombophlebitis, cavernous sinus thrombosis, meningitis and brain abscess. Surgical management, intraoral incision is done in the retromolar triangle, lateral and parallel to the pterygomandibular space. extending between the ramus and the posterior and medial aspect of the medial pterygoid muscle where the blunt incision is performed. No intraoral incision or contraindicated if there has been no matter how minimal it is. Extraoral incision 2 cm along the anterior border of the SCM muscle. Combined approach. Combined is both intraoral and extraoral approaches. This approach provides direct access into the lateral pharyngeal space and aids in the placement of the correct extraoral incision in the swollen face. So the lateral mucosal incision, the curved hemostat is passed lateral to superior constrictor muscle and medial to the medial pterygoid, and the tip of the hemostat is palpated extraorally, and a cutaneous incision is made over the tip. And nick is done. So retropharyngeal space, also known as danger space. So danger space is the midline space lying posterior to the pharynx and anterior to the prevertebral fascia, extending upwards to the base of the skull, inferior to the ear. These are the anterior borders and the boundaries located to it. Next, the source of infection for the fasciitis is suppurative adenitis, dental infection diffusing to the adjacent spaces, nasal or pharyngeal infection. Clinical features: pain, fever, stiffness of the neck, rolling and dysphagia, and supraglottic edema causing airway obstruction, aspiration pneumonia, acute midnitis leading to emphysema and pericardial effusion. Surgical management: intraoral incision, vertical incision lateral to the midline of the pharyngeal walls, extraoral incision along the anterior part of the sternocleidomastoid muscle and inferior to the hyoid muscle. Carotid sheet and the sternocleidomastoid muscle is retracted labially. Blunt dissection is done between the carotid sheet and the inferior constrictor. Prevertebral fascia, it lies in the front of the prevertebral muscle, extends from skull base to T4 body, getting attached to the anterior longitudinal ligament, extends around the subclavian artery and brachial plexus and becomes axillary sheet. Phrenic nerve lies behind, sympathetic trunk lies in the front, cutaneous branches of the cervical plexus it. Prevertebral spaces boundaries, superiorly base of the skull, inferiorly extends the level of the T7, T8 vertebra, anteriorly alar fascia, posteriorly prevertebral fascia, laterally carotid sheet. Infection in this space have an unprogressed towards the mediastinum. Ludwig's angina, first described by Ludwig in 1836, is infection of 5 spaces: submental and bilateral submandibular and sublingual spaces. Clinical features: rapidly increasing board-like swelling of the floor of the mouth, elevation of the tongue, dysphagia, swelling and sperm, painful, diffuse with no localization, difficulty in swallowing, eating, breathing, increased temperature, rapid pulsating respiration. These are the clinical pictures you can see: bilateral wood-like swelling, airway obstruction, and double chin appearance. The other clinical features are edema of the spaces, paucity of the pus, edema of the neck, floor of the mouth and epiglottis, dyspnea, loss of airway, hot potato voice, odynophagia, drooling, tongue swelling, pain in the floor of the mouth, restricted neck movement, unilateral sore throat. Spread to the paranasal sinus, most commonly infection of the maxillary sinus, maxillary sinusitis, resulting from the spread of infection from the periapical abscess of the maxillary premolars and molars perforating the sinus, flow to the involved sinus mucosa. Infection to the paranasal sinus may also spread to the other sinus and nasal cavity and also spread further to reach the kidney cavity and brain. So this is about the paranasal sinuses. So now to summarize, we discussed about the fascia, what are the spaces present, what are the infections will occur from the spaces, boundaries related to it, clinical features of different space infections of the head and neck, and the surgical management, how to prevent it. So thank you.